I really liked the title that it gave me, that is quality of life, the toughest goal to achieve. So, well, first of all, let us introduce how we collect quality of life. Quality of life is a patient-reported outcome. And the patient-reported outcomes is any kind of report that tell us about the health status of a person that is directly collected from the patient without interpretation of a clinician or anyone else. So it's quite a broad area, and actually this provide vital information that only the patient can tell us. It actually helps to facilitate a shared treatment decision along with clinical data and identify problems and concern to improve progress. So I would introduce this idea to say, well, we are in a situation in which already regulatory agency ask the companies that actually perform a registrational study to collect the patient-reported outcomes. And so this is already a must, an issue. This is FDA, this is EMA. You cannot perform a study without collecting that. But what we are still far away is, are we collecting patient-reported outcomes at a clinical level? And more than that, are we able to use them in our clinical practice? So before beginning, can I ask you all, who of you is collecting routinely, not for research, patient-reported outcome in your HIV clinic? Please raise your hand. 2, 3, 4, 5. Okay, and so very few. Okay, and so mind you, I will be quite strong to say, if you do not collect patient-reported outcomes, you can never say that you have a patient-centered approach. Okay, and actually, this beautiful paper that is written by Jeffrey Ladrus tell us that really, how can we know what our patient needs unless we ask? And actually, we know that there is a lot of research that still need to be done, not just about how to collect, what to collect, but rather how to use in our clinical practice. And of course, what we are doing is to try to use patient-reported outcomes, preferentially that are questionnaire, preferentially that are validated questionnaire, to adapt in our need. But really, what we are still missing is a tool that let us listen to the patient. And mind you, ideally, the best way to think how to work at a clinical level is to have a use at an individual level in which really the pros can improve a clinical decision-making. And so can tell us about symptoms, preferentially bothersome symptoms, but also try to introduce and facilitate the patient-physician relationship and identify issues that are related to quality of life. That is the ultimate goal of treatment. But mind you, PROs is not just for individual level. It's very important at an institutional level because it really enable comparison regarding performance. And so actually, we should rather ask our healthcare system to demonstrate a performance. Are we able to provide to all people living with HIV in my country the same standard? Is it true or not? But even more, at a population level, really able to identify disparities. Mind you, it is so much important to identify this, for instance, during the COVID pandemic, in which we realized that COVID was affecting everybody, but the effect of COVID was so much diverse according to the population vulnerability. Okay, this is patient-reported outcomes. So one of the most important patient-reported outcomes is quality of life. And guidelines now says, well, the fourth objective is to obtain 90% good health-related quality of life to all people. What does it mean? It means that beyond viral suppression, we need to reach high quality of life to 90% of our patients. Well, let me say, what is quality of life? It's an individual perception of their position in life in the context of culture and value system in which they live, and in the relation of the goals, expectation, standard, and concern. And so we are speaking about health. We are not speaking about diseases. And actually, we realize that this refers very much to the environment where we live, okay? And in the pre-art era, I was doing research. I was in a clinical team in which we were trying, I remember, I started my career in the DDI registrational trial. And says, oh, what a beautiful drug is DDI. Okay, at that time, we knew that we had no viral load. And actually, in order to say how good was the drug, we use a quality of life questionnaire. We use a Karnofsky performance test. Okay, actually, we realized that we wanted to have an impact. After that, we had other biomarkers, and we missed about the quality of life measure. But really, we knew since the very beginning, the first trial on AZT used a quality of life performance test. And actually, we know nowadays that clinical trial should always incorporate a measure of quality of life. And mind you, the issue is that we can have lots of quality of life tools. Some of them are disease specific. Mind you, all of these disease specific quality of life were performed mainly in the pre-art era. And so nowadays are really very old, and actually some of the domains that they collect, like for instance, the number of admission and the severe side effect, are no more appropriate according to what is the clinical manifestation of HIV. And so it's interesting that now we are more and more moving into a more generic instrument. There's some very easy to use. I will present you AQ5D, 5L, but of course there are some that are much more detailed, like for instance SF36 or the shorted version that are mainly used in clinical trial. This is what is the most widely used. It's just 6 questions. Actually, we identify 5 domains, that is mobility, self-care, usual activity, pain and discomfort, and anxiety and depression, and we give a score. But there is also a very interesting 6th question that is a visual analog scale that tells you in the last 24 hours how you collect your health status. Mind you, these tools are not tools to measure quality of life as a whole, but health-related quality of life. And so, first of all, we need to understand that quality of life is a very broad, and we need to collect something that is more related to our health. And of course, we can build up data about mental health and physical health. And so, I should not be here, because if I should be really ashamed to present this data. In my HIV clinic, I routinely collect AQ5D, 5L since 2014. Actually, I presented the data of 1,700 people, and these are the histogram of 6,000 questionnaires that I collected in this 9-year period. I should really be ashamed. Almost 50% of my people attending my clinic do not reach optimal quality of life. And so, oh, how terrible is my clinic? And I can tell you that there's not at all any trend in improving this. I search a lot with all my statisticians to say, give me predictors. Tell me how it is that there's 50% of these people that are always in the same situation. There's 25% that increase, 25% that decrease, but the line is up and down. And actually, I cannot tell you which are the predictors above age. And I'm very worried, because actually I don't believe that age per se is something that may decrease our quality of life. I told you about the healthy aging process, and I want that all my patients that get old will increase their quality of life and not decrease it. We are very far from an optimal result. Mind you, in my clinic, 97% have got undetectable viral load, 97%. Okay. Given that, I need to understand that there's many factors that influence health-related quality of life. Having multiple health conditions, social isolation, frailty, financial insecurity, symptom burden, disability, stigma, and discrimination. Mind you, all these items are not collected in a Q5D5L that I'm using to collect health-related quality of life. And of course, if I cannot get all this, I will not explain why the person still tell me I'm not satisfied of my quality of life. And also the issue is that, well, I can do something to improve quality of life. Of course, I can try to improve medication adherence, retention in care, and get a better healthcare system, but still, I may not fight all this. But the point is that collecting quality of life allow me to listen what are, at an individual level, the patient need. Let us go to research first. I told you that research nowadays need quality of life measure. But what are quality of life measure? Do you see clinical studies in which they use a Q5D5L just to demonstrate that you give a new drug and the new drug is fantastic and all your quality of life problem will be solved? You will be happy, you will be rich, you will have a beautiful wife, a beautiful family, you will never get old. Is that the case of a drug we give? Definitely not. And so what we need is that to say, well, there's a lot of things that we need to collect. And whenever I ask the patients about how would you improve, actually, they collect a lot of issues that are related also to the drug. And so I'm worried about the long-term impact. I would like to have less drug. I would like to have drugs I take less frequently. And so even if the drugs are good, the patient perspective, it tells us that there's a room to improve. Okay, and so drugs may not improve quality of life, but there is some health-related quality of life that can be improved. Actually, I give you two examples about which kind of quality of life tools have been used in registrational study. The first is the registrational study about Biktarvy, in which Biktarvy chose just to say, tell me about symptoms related to antiretroviral therapy. And they did an interesting analysis because they chose the two important symptoms. So one is related about mental health, and so sleeping difficulties, disease and nervous anxiety and headaches, and they were able to demonstrate at a single week point if it was better and worse when the comparator. But what is more interesting, that they also were able to have a longitudinal model. And mind you, these were not just symptoms, but were asked to be bothersome symptoms. And so symptoms that make you have difficulties in your daily life. Actually, I show you another study that really refer with regard of Dovato. And actually, Dovato were able to demonstrate persons differently in young and old people. What is the patient preferences? That is, should you go back to your original regimen? And this was even more striking whenever you moved into long-acting. And to me, it was the very first time that in a registrational study, you don't reach a ceiling effect. The more you are in long-acting, the more you are happy about that, the more you will never go back. And actually, this was interesting because this kind of studies also give us the motivation why people want long-acting. And most of these motivation is something that the doctor do not appreciate, do not believe are even so relevant, or were not expected. And so I had a patient a couple of months ago who is 86-year-old that came to me asking for long-acting regimen. He's got multimorbidity, he's taking 12 pills. And I told you, why you were asking to take one single pill above the 12 you take to go to long-acting? And he told me, it is because in this way, I'm sure I can come to visit your clinic every 2 months. Otherwise, I get out from home every 6 months only. That's frightening, isn't it? And so the motivation are so different from patient to patient. Okay, given that, I fight a lot because I thought that patient-reported outcomes should have been included in AACS guidelines. I totally know that it's something that is for promoting, is not yet the standard, but actually what we wrote here is that PROM pertain multidimensional domains and should be chosen properly, and actually, ideally, we should have a validated tool, but not necessary. And actually, what is interesting is that we do not have a comprehensive list of quality of life because of the fact that there will not be a list. But what is interesting is that, of course, you need to ask different things according to your patient you are in front. And so this is an interesting study that the Spanish people did. And so they said, we wanted that the HIV care is high level in all the country. In order to do so, we realized that HIV people are so diverse one another. And actually, we believe that there's a different phenotype. Imagine it's different. A person who is well controlled with HIV, with no comorbidities, compared with a person in the first year of HIV, or in an HIV person with lots of social need, or a pregnant woman. And so what does it mean? It means that we need to think that patient-reported outcomes should really refer to what is the patient that is in front of you, which is the phenotype. I believe that in the future it will be better to detail which kind of quality of which like of patient-reported outcome to collect according to the phenotype that you have. And so actually the Spanish provide you this profile identification, and according to that we will try to identify really what to ask. I go back to the aging issue, and actually in the aging there's a lot of patient-reported outcomes that need to be asked. And so, for instance, experience of traumatic loss of the partner, of the friends, of the families, the social support, the mental health, the feeling of loneliness, and also the possibility to be screened for frailty. Actually, I show you something that we use. This has been developed in Canada by the group of Ken Rockwood. Actually, this is a list of images. The patient-reported outcomes is as simple as there's not even a question to answer. You just see like strips that tells you about the domains, and you click according to where you recognize, and the end, it is the patient himself that tells me the level of frailty. And according to that, I can really identify. Imagine, and so some of these patient-reported outcomes can be used as screening tools. I usually perform to all patients, for instance, chest depression scale, just identify me. Who is the people that experience severe depression or anxiety? And of course, this is something that will be shared with the patient. And actually, who should be assessed? Let me say, everybody should be assessed. So there is not an age limit where to assess. And how to collect. This is a big issue, because so far the way in which we collect is using electronic chart. But of course, internet illiteracy is still there. And actually, we know that the person who are internet illiterate are presumably the person who's got higher needs. And so this is important. We will see shortly tools like this is called Promise, is like a website that will turn to be publicly available, in which everybody can use this website, in which can invite people to collect several domains about quality of life. And of course, this will also be available in other tools, like, for instance, joining with a wearable device, like it can be a watch or even a voice assistant. So we have, for instance, developed a voice assistant tool in which through Alexa, we ask questionnaire to all the people at home. And of course, this is an interesting way to do it. Well, let me say, pros are valuable tool, and as they can be used, are the voice of the patient. And so mind you, I use pros in order to listen the patient. And is it time consuming? No, it's actually the opposite, because I know the pros before the patient comes. But there's something I would like to stress. Sorry. Please do not collect patient-reported outcomes if you are not able to return to the patient. This is not ethical. You do not collect the CD4 without telling the patient the CD4 value, what it is. Do not collect any of patient-reported outcomes without returning the patient result. And so I will give you my clinical practice. In the metabolic clinic, people receive a WhatsApp message, an email to say, well, remember, next week you have the visit to us. Please fill this questionnaire. Okay. And I would say 50% will not. And so there is a reminder 2 days before, oh, you are still not doing the PRO. Mind you, this needed to be discussed with the doctor when you come. And actually, there's also what we call a yellow box. And there's something that is so much very important. That is a simple question to our patient. A, what you would like to discuss with your doctor next time? And whenever I get in front of the patient, there is my electronic patient chart. It pops me the yellow box. And sometimes I unexpected to see a 70-year-old woman that tells me I would like to discuss about my sexual dysfunction problem. Okay, they will never tell you in a face-to-face. And so they're able to write, but they will not tell you. Okay, or really many issues that relate to other issue. For instance, I would like to change the drugs. What about statin? I've heard statin are so bad. I don't want to get vaccine. I want Ozempic to get slimmer. And so all these issues. So a lot of things. And so my impression is really that, well, PROs can generate some quantitative and semi-quantitative measure to screen for diagnosis. I told you about frailty, I told you about depression, I told you about sleep disorder. And of course, this is very important because I will use this information with shared decision. Should we change the drug? Should I refer you to a specialist? Should we start some treatment together? But also, there's some simple question that broadly related to a higher concept of quality of life, not just health-related quality of life, that allows the patient to identify where the problem is, that will empower the patient. And so I believe that really what we wanted in AI's guidelines, that the utilization of PRO may facilitate the dialogue between the provider and the patient. They may improve the patient and the physician awareness about their own health and introduce a patient-centered care approach and empower the patient in this conversation. And so this is my final slide. Really, I believe that it is good to keep this as the ultimate goal. The PRO represents the voice of the patient. And if you don't ask, you will never know about that. The use of PROs must increase and must help to have a patient-provider communication in order to act, in order to have a shared decision method. Thank you so much.